Good afternoon, everyone, and welcome back to our Contagion Live podcast. It's a great day to interview another fantastic guest. Today we have Dr. Jose Alexander, and I'm going to jump right to him and let him give a little bit of background, maybe briefly discuss your background and kind of how that intersects with our topic today around AMR and diagnostics surrounding AMR.
Thank you, Remy. So my name is Dr. Jose Alexander. I'm a medical microbiologist and a medical technical director for the Advent Health Microbiology Services in the Orlando area. I trained originally as a physician. I practiced medicine years ago, but my focus now is more in the laboratory perspective to be able to provide clinical guidance and clinical liaison to clinical team and the technical aspect of the microbiology lab.
Fantastic. As you might know, and I know our audience knows, this podcast really is looking at that very thing, right? We're trying to help the medical community kind of understand the really critical intersection between the medical laboratory as well as the clinician side and kind of that interaction. So let's jump right into it. We found one of your posts on LinkedIn is at least how I learned about you with respect to you working with KPC31. And so let's just jump right into it. If you could provide an overview of KPC31, which we know is a variant of KPC3, and kind of the concerns surrounding this particular pathogen.
Yeah, so it's a very interesting variant, and I think as a microbiologist, especially from the laboratory side, I think it's important for us to consider that screening that we normally being implemented for carbapenimases is kind of a living algorithm. We need to adapt to these variants that they pop up around the world constantly. So KPC as a carbapenemase, we know that being a carbapenemase affects carbapenem, but also cephalosporin, penicillins in general. And we have some beta-lactamases inhibitors in clinical use, like avibactam, babubactam, relabactam, even durlobactam. They're able to inhibit KPC. And this is one of the interesting approach, a change on the antimicrobial therapy when we were able to get access to those inhibitors, and now we be able to face carbapenemases. We have other carbapenemases like metallo-beta-lactamases. They have a different perspective, different spectrum of activity. But in general, we know carbapenemases, the defining factor is the capability to hydrolyze carbapenems. So KPC31 become a very interesting variant, and it's been found in multiple places in the US and been previously described, it's well known. It's just one single mutation in the primary structure of the protein, the amino acid change, in the position 179, aspartate change for tyrosine, and this is close to the omega loop. So they change the structure of the enzyme, specifically the active site. And we know how beta-lactamases work. Well, the only purpose of beta-lactamase is to accommodate the beta-lactams in the active site and break the beta-lactam ring. So this changed the whole spectrum and affinity, because now these enzymes have a high affinity for ceftazidime and a reduced affinity for avibactam in presence of the ceftazidime. That I think is a very interesting approach, because ceftazidime avibactam has been one of the battle horses against KPC during the last 10 years. So now we have this enzyme, this variant, that is able to confer resistance to this combined beta-lactam inhibitor. So this also put a perspective on the laboratory, because this change in the KPC31 made KPC31 susceptible to meropenem and imipenem, ertapenem, so carbapenems. So we know that the activity against carbapenem is decreased or lost, but the increase on activity against ceftazidime is also present. One of the interesting things with this ceftazidime avibactam, something that we observed in our facility when we found the first one this year in Central Florida, is that when we put a combination of ceftazidime with avibactam in the system, when we put a different antimicrobial, in this case Astronam with avibactam, it's actually susceptible. So the resistance doesn't seem to be linked directly to the inhibitor, because when we put ceftazidime with babubactam, we still see ceftazidime being resistant. So seems like the affinity for ceftazidime is in some way modifying the active site and don't allow the inhibitor to be able to block the enzyme. So seems to be antimicrobial specific. So, and I think the substrate specificity is something really interesting in this group of enzymes. But this put a risk in the laboratory, as I mentioned, carbapenem being susceptible, since carbapenem resistant is exactly the point where laboratory decide to screen for carbapenemase. So this enzyme, KPC31, phenotypically behave as an ESBL.
Yeah, I mean, it's such a great conversation, especially like you mentioned, if you're a medical microbiologist and then you're interacting with that clinician that, sometimes you may, and being an MD yourself, right? So you have kind of both backgrounds growing there. It's always kind of interesting in my world how that gets communicated, like for effective treatment. Follow up with you, you talked about your recent ability to identify this particular variant, and you were actually able to sequence the entire genome through a series of different diagnostic tests. Can you kind of take us through that process of what you were looking at?
Well, we've been lucky enough in the last 2 years that we've been working with whole genome sequencing to bring as a tool, a clinical tool. Some of them as a direct, rapid clinical tool for identification. But now we are able to implement, we now have it implemented as a clinical tool for identifying mycobacteria and fungi and some bacteria, but also is being used for exploring this challenge. So in this particular case, we have a patient that was very well known for our facility, a patient that have come to our facility multiple times from a long-term facility. Patient having multiple KPC during a whole year of admissions. And this patient, the first culture they had in the admission was actually a blood culture. So when we performed the rapid BCID, we found a Klebsiella pneumoniae with KPC. So from the laboratory perspective, blood culture is the only culture where we do genetic testing before phenotypic testing, because we have access to the positive blood culture.
Right.
If this isolate were from urine, would be completely missed, because this will look like an ESBL. But because it came from blood, we were able to detect the KPC. And when the phenotypic susceptibility came back, there was a discrepancy. Carbapenems, as meropenem, was susceptible. So after repeating the test, we found out that actually was susceptible, and ceftazidime avibactam came back resistant. So they are automatically trigger the alarm for this specific pattern of the KPC31. So we decided to do a whole genome sequencing. We've been able to implement a read whole genome sequencing application. And then after we do the whole genome sequencing, we start evaluating. And the first thing that we did was, well, what type of strain are we working with? So what is the MLST of this strain? So we found there was an strain 307 that is a hypervirulent strain that has been reported globally and in some regions in the US too. So this is actually being reported with KPC31. When we start evaluating the resistant mechanism, genetic mechanism that this organism have, we found a KPC31. We found 3 beta-lactam ESBL plus other penicillinases was resistant to tetracycline, quinolone, fosfomycin, so aminoglycosides. So the whole picture actually matched the strain virulence. So also some mutation on the porins that explain the whole spectrum of multi-drug resistance of these organisms. So as a diagnostic tool, this process took a few days to be able to accomplish. We didn't see this as a direct tool for clinical care, but we see this as an opportunity to modify protocols that we currently have. And this is why it's so important that we are able to see a screening of antimicrobial resistance by phenotypic testing from a completely different perspective. We now have to consider not only way for carbapenem resistant, maybe we need to include ceftazidime avibactam, meropenem babubactam, or imipenem relabactam in our first line of testing, not necessarily for reporting, but to be able to account for these variants that we see that KPC31 is just one of them.
Yeah, it's fascinating, right? I've been working for 30 years in medical microbiology, and it takes me back to when, really all we did was phenotypic testing. And so again, for the audience, when you're kind of thinking about this, right, some of you may have been doing this a long time and you're thinking about, that phenotypic way of identification, whether it's a BITEC or something like that, or a microscan or what have you. Now, we're kind of at the cusp of this whole genome sequencing issue, multi-locus sequence typing, which you heard in the conversation there. So I think, for the more elegant types of testing platforms that we have now, it's just something for our partners and really everyone to consider, right? That phenotype is really still important, but now we're really considering genotypic expression and different profiles that some of these, and we know some of these
Yes.
some of these agents are deadly, especially if they're bloodborne and things like that. So, we're kind of getting at that a little bit, but can you talk a little bit more about, in your kind of professional view, why it's so critical to kind of get to that level of granular analysis down to that variant?
So for us, one of the important thing is because it's such an interesting organism for the perspective that is able to escape a routine method of identification. So we have organisms that are multi-drug resistant, multiple classes, multiple groups and species that we probably expect them to be, like some of the Pseudomonas, Acinetobacters. But when we found an organism with such an interesting pattern, created question for us was, what about if this patient, the first culture was a urine instead of a blood?
Right.
So this organism would be easily considered to be an ESBL. Cephalosporin resistant, penicillins, carbapenem susceptible. There is no reason to test for ceftazidime avibactam or penibambobactam. This organism would be flying under the radar, and who knows for how long it has been.
Right.
So for areas where this organism has been reported, I think it's important for laboratory to consider an expanded algorithm for screening. And I think that's also the important point, not only to have access to those agents quickly, like in the first line of testing, because if you have a KPC, you can release those antimicrobials quickly, but also as part of a more comprehensive approach, because molecularly speaking, or phenotypically speaking, KPC31 should be classified as an ESBL because that's what it looks like.
Right.
Even when we know that it's a carbapenem, it's part of the KPC. So we normally go through the level of NGS sequencing and analysis when we have such interesting pattern that we know they can also have an impact to the not only clinical, but beyond that, epidemiological. So we want to make sure that we have the tool to, when these organisms show up again, we're able to identify with the routine tests that we normally have.
Right, right. So important, right? And I know, I'm sure you feel you're very fortunate to have that type of testing modality. Always when I talk to colleagues that may not, they may be out in a rural setting or something like that. It's so critical, I think, to spread this type of information around, because what happens is, if nothing else, you should at least be thinking that you might have something, especially right if the patient's not responding or you got something going on weird that you might want to back up and do something. Can you kind of talk? Go ahead.
And I want to mention that the patient was, after we started doing the evaluation, and the first time the suspicious was a KPC31. So we activate the entire clinical team, the ID physician, ID pharmacist, and the patient was put in meropenem quickly, and the patient improved. The patient was discharged.
Great.
So, and that was an experience for us, because that could be a completely different scenario. I mean, for phenotypic testing, we would see the difference in testing, but that would be 2 or 3 days down the line. So we know that how many patients with sepsis can actually deteriorate so quickly. So I think that was part of our idea too, that in the next time that they show up in a completely different source, we want to make sure that we have the tool for identification.
Yeah, right on. I mean, you literally just hit the head of our podcast title, right? From pathogen to infectious disease diagnosis. Yeah. So that's why we're so excited to get you on, because I mean, again, it certainly can be missed, right? Even in labs that might be pretty well equipped. So I think that ability for us to share this, I know a lot of this gets published and things like that, but I think in a practical way, at least for me in an academic setting, I'm always trying to bring these types of conversations into that realm of the physician, the clinician, the pharm, the ID pharmacist, the laboratory, how critical it is to have those types of conversations and share that information, not just within your same institution, right, but outside. So again, I appreciate you doing the podcast for us. It's so important. Can you talk a little bit about the importance of differentiating AST, antibiotic susceptibility testing for treatment versus AMR screening?
Yeah, so I think with the change of when we were access to the multi, for the as a laboratorian, that you and me, we know, and for the audience, that was such a change in the lab, having access to the multi, right? So we don't have to wait 24 hours for identification. You don't have to use a generic gram-negative susceptibility card. Whatever organism show up, you have at least half of the card can be reported. The other half probably it's not going to be used. So I think the MALDI gives us the opportunity to know, before we set up the susceptibility, what organism are we dealing with. And I think at this point, I believe that having susceptibility panels that could be narrowed to a specific group give us access to real estate on those cars. They not only provide tier 1, tier 2, tier 3 organisms, but provide susceptibility testing for some of those antimicrobial resistant agents. So, and that also opened the opportunity to have a more comprehensive phenotypical analysis. So an Enterobacterales card that give me access to not only penicillin, cephalosporin, and carbapenems beside other agents, but give me access to ceftazidime, avibactam, meropenem, babubactam, will allow me to create an algorithm that if I have Enterobacterales, they look like ESBL, but ceftazidime, avibactam test resistant. So at least that's an alert that we've been dealing with one of these variants that actually escaping the carbapenem resistant typical pattern that they normally have. So the same thing, having access to some of those agents for some of the non-fermenters like Acinetobacter, Pseudomonas, that some agents are very specific for them. Having that approach, I think, is critical. So having the testing not only for releasing what is necessary based on the level of resistance. So we don't want to release agents that are not clinically necessary because the organism is multi-drug resistant. But you can use those agents as part of a comprehensive antimicrobial resistant analysis, can give you a little more of an opportunity to be able to target these variants or even future resistance that will continue to be rising, how we know. But also will give you access to have results for those agents that could be beneficial for antimicrobial resistance without having to wait 24 hours for additional testing. So I think seeing antimicrobial testing from the perspective not only from treatment, but also from the perspective of having a more comprehensive screening, I think that is something that we've been trying to do with conversation with some of the manufacturers to try to have this approach, because we want to make sure that we are able to account for those new challenges that constantly are arising.
Yeah, that's great. I mean, it really makes you think about, bringing in the, you kind of hit on it a little bit. We often forget to think about the industry side that, we need to be talking with them, and especially in AMR, right? Because we know pathogens and across all spectrums, fungi, whatever we're dealing with, are changing so rapidly that sometimes the manufacturing industry have to be brought in to think about. I mean, it's really an evolution that happens monthly, right? I mean, you almost have to be thinking about your next generation of cards or panels that you're looking at because it changes so rapidly. So I appreciate that comment. It also makes me, as an academic researcher, think about who's teaching at the bachelor's level for medical lab scientists, how critical it, and we do this, but it's like constantly changing, right? That we get that basic understanding of clinical micro and susceptibility down, but then now the challenge for new graduates is to think about, okay, what you're talking about. You've got to be on a next level understanding of the molecular, kind of at the intersection of microbiology, and maybe moving into those diagnostic management teams with the doctorate level of a medical lab scientist. So all good stuff. So if you were talking to a clinician and a laboratory professional, what kind of advice would you give them in trying to capture these types of results if they are interested in kind of moving this way?
So one is that communication is critical, right? Having an open communication with the laboratory. And as an experience with my own team, when you have access to a microbiology laboratory, you have access to such an amount of expertise in the micro area that I think is critical for clinicians, physicians, pharmacists to understand that that level of expertise is present in your institution. So being able to have that conversation with them, gather that amount of data and additional information, they can guide not only the management, but can also treatment from the treatment perspective. The other point is to be able to engage in conversation and how some of these challenges can be addressed. For example, if we know that we have a problem with a specific antimicrobial resistant organism, let's say DTR Pseudomonas. So being able to understand phenotypically what are the best agents that perform in vitro that we know they have clinical activity or indication, because if those agents will take 24, 48 hours to be tested, having that cumulative data can actually drive antimicrobial therapy before those susceptibilities are available, but you already know that you're dealing with a DTR organism. So I think using cumulative data to create laboratory algorithms that can be triggered just by a specific pattern. We also alleviate the overcall of the laboratory, asking for additional testing, asking for confirmation, and pharmacy and the ID physician can actually escalate treatment immediately. And it's
Right.
better that they escalate later when we know that the organism, it probably no ADTR, but we can have, it's always better to have the patient in broad spectrum and escalate that vice versa, right? Having a drug bus mismatch. So I think that is, for me, my message for clinician is communicate with your microlab, with your pharmacy, also with the pharmacy. They play a significant role in this triad of patient care and even infection prevention, and trying to define what type of antimicrobial resistance are you seeing. What are you challenged? What are the agents that you have available? And how those agents perform against that organism. Always they have clinical indication and trying to be a step ahead of the testing as much as possible.
Yeah, I love that. Again, I'm glad I've gotten to meet you online, kind of in person, because you're really hammering home the point of things I've been discussing with a lot of colleagues. The physician clinician, the medical laboratory, i.e., the microbiology expertise, the pharmacy team, and IP, right? Infection prevention can get in there too. So those types of communication tools, if you're out there listening and you're kind of thinking about doing this, I think you start there, right? You start with people that can sit down at a table, and you need to meet regularly to kind of discuss the types of profiles you're seeing in your laboratory, in your region of the country, in your region of the world, for that matter, and then understanding the patient.
Exactly.
All of that's still important, where they're coming from and things like that. So I really can't thank you enough. And I thought I'd let you, if you have any final words or thoughts, maybe give any other thoughts you have about the topic.
Well, in the aspect of antimicrobial resistance and this collaboration, I think it's also important to, probably we are at a level that criteria for multi-drug resistant, antimicrobial resistant for infection prevention probably can look different of criteria for multi-drug resistant for treatment perspective, right?
Right.
So if we have a multi-drug resistant Pseudomonas, but it still has susceptibility to some agent like Staphylococcus and Tazobacter, we probably want to isolate the patient. But that doesn't necessarily mean that we need to do testing for some high-level broad-spectrum antimicrobial. Patient can be treated with antimicrobials that we already have at the tier 1 level. But the organism is resistant enough to keep it isolated because we have to be conservative in that aspect. But a different perspective is if we have a multi-drug resistant or a DTR, difficult to treat Pseudomonas, they don't have any other first, second, third line antimicrobial, we need to escalate. Patients still need to be isolated, but treatment. So being able to define certain antimicrobial resistance from an infection prevention and therapeutic perspective, I think that can also facilitate optimized testing, optimized process, and from the perspective of the hospital, the care, we want to make sure that some patients require isolation, but not necessarily required to be in broad spectrum antimicrobial.
Right.